Okay, we're going to start into part 3 of musculoskeletal deviations. This will be on our other disorders like arthritis and other connective tissue disorders. So let's get started right away. Arthritis is inflammation of a joint or joints. Basically, it's progressive articular cartilage deterioration. It's slow, progressive, non-inflammatory disorder of the synovial joints. It leads to progressive loss of the articular cartilage that leads to bone spur development. It's common as people age, but not a normal part of aging. It's also not a systemic disease, so there are not any systemic signs. This does primarily affect the weight-bearing joints. So you'll see this in people's cervical and lumbar spine, their hips and their knees, and you'll also see it in their fine joints as well for those who use their hands a lot for things. So one of the other risk factors, there are several risk factors for it, but risk factors, of course, would be age, decreased estrogen at menopause, obesity, previous injuries, or jobs that keep people frequently kneeling or stooping. One of the important things to note is that a 10% loss in weight can improve function 28%. So a person's weight has a lot to do with how arthritis will affect them. And those who don't get regular moderate exercise increase their risk of having osteoarthritis or degenerative joint disease. So the initial symptoms of osteoarthritis include pain with joint movement. Haberdin's nodules occur on the fingers, the distal end. Stiffness with osteoarthritis is worse right after they rest and then decreases with movement. That's the stiffness that it is, okay? So basically they're stiff when they get up, but it starts to get better as they kind of get those joints oiled. It's generally unilateral, so one of the joints. So the joint deformity, we talked already about the Haberdin's nodules. Those are distal on the finger, and then you have the Bouchard's nodules. You might have a varus deformity or a shortened extremity. In order to diagnose it, we do use imaging to identify the loss of a joint space. Biomarkers are normal. Labs are normal. With the exception of occasionally you may see an increased SED rate due to an exacerbation of the arthritis. If we were to test the synovial fluid, it would be clear yellow with limited or no inflammation. So again, this is a localized disease. It's not systemic. So, and to just clarify, so the pain does worsen with joint use. So the early stages, rest does relieve the pain, but later the person may have pain with rest and trouble sleeping due to the joint pain. And pain may worsen with lower barometric pressure. So those are your folks who say, oh, I can feel the rain coming in. It's set into my knee, right? So they'll know it's what the weather holds in store for them because of their arthritis. So, guys, there's no cure. Treatment does focus on pain and disability and managing the pain, preventing disability. For acute inflammation, we do rest them, keeping joints in a functional position, but avoid prolonged rest. We could use ice for acute inflammation. Otherwise, we use heat. Weight loss should be encouraged and assisted with. Exercise, including range of motion, things like Tai Chi, some of the lower impact. Surgery may be necessary. A person may need a joint replacement. Home safety is a concern, especially with the use of adaptive equipment and people with stiffness and ability to possibly get up the stairs and down the stairs, so risk for falls and tripping hazards. And I guess we'll start to talk about the medications. So Tylenol for mild signs and symptoms, not to exceed our 3 grams daily. Topical drugs, things like capsaicin would be used. Now, mind you, there are topical preparations for things like that would be NSAIDs that would be topical. Careful with those, even though they're applied topically, they are absorbed through the skin and systemically absorbed. Steroids may be useful, and not just by mouth, but also injected into the joint space. Salicylates, so those aspirin-containing medications, NSAIDs. But for any of those, remember you have to monitor them for signs and symptoms of a GI bleed. And then COX-1 and COX-2, these were those COX-2 inhibitors. They were supposed to be the most amazing drugs, but we found out that they were causing massive cardiovascular issues with adults, and they ended up killing a lot of people. So the only one that's still left on the market now is Celebrex. And then as far as disease-modifying osteoarthritis drugs, currently there aren't any, but they are looking to try and develop some. So that's osteoarthritis. Now we're going to move on to some of the rheumatic diseases. So rheumatic diseases are inflammatory autoimmune diseases that lead to degeneration or permanent damage. So you can see those listed here as in red. So they're important to know that rheumatic diseases, of which rheumatoid arthritis is just one of several rheumatic diseases. So we're going to use rheumatoid arthritis as our exemplar today. So rheumatoid arthritis is a chronic autoimmune disease that affects the connective tissue in the synovial joints. It affects all ethnic groups. The incidence does increase with age, peaks between the ages of 30 and 50. Approximately 1.5 million Americans, more likely to occur in women. It is basically autoantibodies, the rheumatoid factor, combines with IgG and causes the inflammatory response that results in joint destruction. There is a genetic predisposition, which is important to the development, and we know a lot of this because we can test for human leukocyte antigens, or HLAs. And smoking can increase the risk in patients who are genetically predisposed and may actually interfere with their treatment. So as far as the pathophysiology and clinical manifestations, so here's the patho. The pathophysiology is basically T helper cells secrete cytokines, which causes inflammation, and that causes something called pannus, which makes these villus projections, which invade the cartilage and changes the articular cartilage into pannus, and then we get granulation tissue, which is scar tissue, right? Destroys the cartilage. So signs and symptoms of rheumatoid arthritis are systemic. They may have anorexia, weight loss, and fever, morning stiffness that lasts longer than osteoarthritis, tender, painful, reddened joints. They may have an ulnar drift, a swan neck, a boutonniere deformity. And I'll just pop you up to this so you can see those. I have those listed here. There's the ulnar drift and the swan neck deformity there. So coming back down onto this, rheumatoid nodules can break down or they can become infected. They're usually not removed surgically because of a high probability of recurrence. So even though they have those rheumatoid nodules, they are just left there. And then there's also usually they could come with other autoimmune disorders. So something like Sjögren's disease, they could have dry eyes. So how is rheumatoid arthritis diagnosed? So rheumatoid factor is found in about 80% of rheumatoid arthritis patients. We also have the anti-CCP, which is an antibody specific to rheumatoid arthritis. CRP and sed would be elevated. And remember, something like that, it should decrease as our therapy is effective. If you were to test the synovial fluid, it would show that there were white blood cells in there and it would be slightly cloudy. Even despite having some diagnostic things, it's still a tricky diagnosis, right? No single test will show you that somebody has rheumatoid arthritis. In fact, somebody could have rheumatoid and have a negative rheumatoid factor. Sometimes the symptoms overlap some other diseases, and some people have mild disease and some people have severe disease. And it does take time for a lot of the symptoms to develop. And the other thing to think about is that the older a person gets, the more difficult it becomes to treat them. A lot of the medications are tough on the body. Renal function decreases in the elderly, so a lot of our medications kind of affect them that way. And then any effect on them intensifies and increases their risk of overall safety concerns and ADLs and entire life management. All right, so we're going to go into some of the medications for rheumatoid arthritis. We have a couple different classes of medications. The first three that you have listed up here, the analgesics, the NSAID, the glucocorticoids, they actually don't prevent joint destruction. All right, so in order to prevent joint destruction, we need to go into the DMARDs. Those are disease-modifying anti-rheumatic drugs. So we use the ones up top for pain and the ones down below to kind of stop the progression of the disease or slow it down, may not stop it. So, and under those DMARDs, we have two different classes. We have our non-biologics and we have our biologics. So I'll take a moment, reflect on this slide, and then we'll talk about some more of the medications. All right, so some of our DMARDs, one of them is methotrexate. Methotrexate is to be used in early disease. We used to not start it right away, but now we know that the earlier they start the medication, the better it is for them. It's not very toxic to the patient, but it can cause hepatotoxicity and bone marrow suppression. It may take 4 to 6 weeks to work, but it's also teratogenic. So the patient, if they're of childbearing years, should be taking contraceptives during therapy. And then we have sulfasalazine and hydrochloroquine, so Plaquenil. Those are very common medications to see. Sulfasalazine is for mild to moderate disease, and you want to drink enough water and use sunscreen with that one. And hydroxychloroquine, also for mild to moderate disease. Things to look at that, they need a baseline eye exam and then a follow-up every 6 to 12 months. Plaquenil can cause retinopathy, right? So if the patient develops signs and symptoms of impaired vision, like blurred vision, then that medication should be stopped. You have to let the doc know about that. Leflunomide is also teratogenic, so the person should be on a couple different forms of birth control if possible. Don't use it during pregnancy. Xeljanz is one of the newer ones, all over the commercials. It's a JAK inhibitor, so we heard about that under some cancer. It's for moderate to severe disease. Because of that, of its action, you are not to use any live vaccines with that medication. All right, let me see what else we have here. Now, this class of medications that we're going to talk about are the biologics. So, biologic BRMs or biologics, they slow progression of the disease. These are immunotherapy, also called, they are your TNF inhibitors, so tumor necrosis factor. So biggest thing to be aware of these is a lot of them are monoclonal antibodies. You can see that by their names. They're MABs and they're CEPs as well. So it could be TNF is CEPs and monoclonal antibodies are MABs. But you need to always have a PPD or a TST and a chest x-ray before starting. They're at high risk of infection and no live vaccines for here. Okay, so those are the medications, some of the exemplars that you should know about. And then here are some of the other ones. Anakinra is a sub-Q injection. And I guess that's all I've got to say about those. It's a sub-Q injection. So these are just some actions of some of the other biologic response modifiers. All right, so management of the diseases, right? So the nursing goals are to decrease pain, maintain functionality, and protect the small joints. This is why we split them before there's a deformity. We use heat and cold application, range of motion, work with OT for that sort of stuff, PT for the large groups, and OT for the small. Patients are advised to avoid repetitive movements. They should sit if they're doing household chores to decrease the stress on joints. Position the joints in the extended position, neutral. Surgery might be needed. Arthroplasty of the hands is a common surgery. It's to restore function, not to correct the cosmetic deformity or treat the underlying process, and the person will need hand exercises after surgery. Taking warm showers or baths is actually recommended to help relieve joint stiffness. Isometric exercises aren't recommended. And if they are to do any stretching and range of motion, they should do it later in the day after the joint stiffness has decreased. So these are just little helpful things for patients. And then some of the other treatments that we didn't really talk about, NSAIDs, they can take 2 to 3 weeks to be effective. So I'm just going to pull us back up on this slide just so we can look at our NSAIDs, right? That they may take some time to be effective. Aspirin, non-aspirins can increase the risks of clots and CVA. And aspirin, if they were to take it, would be 3 to 4 grams daily, and you can monitor those aspirin levels. And then steroids, injection into the joint can give them local action, and low-dose systemic corticosteroids are not effective. They are not to be sole therapy. And remember that there are side effects for steroids. They can cause diabetes. They can increase infection risk. So things to just monitor for with that. So we're going to go pop back down to where we were, which is the differences between the two, right? What's the difference between rheumatoid and osteoarthritis? This is a very good comparison. So rheumatoid arthritis is systemic, and you will have abnormal labs. Osteoarthritis, you never will, right? So I would take a moment and reflect on this information. And then here's a comparison of the joints, how they look, a normal joint, and then how osteoarthritis looks and how rheumatoid arthritis looks, so you can see the difference in them. All right, so we're going to move on to gout, which is also called the disease of King's. It's a type of arthritis with hyperuricemia greater than 6 milligrams per deciliter. And that is a result of purine metabolism, which in turn causes crystallization and inflammation. It can be genetic or acquired. It is characterized by flares and remission. So somebody who gets an acute illness can trigger this. We also talked about hyperuricemia under cancer. And the goal is really the same, right? To decrease the uric acid levels because the uric acid can harm the kidneys. So stone formation can result, kidney disease can result. Alcohol and caffeine can increase the uric acid level. All right, so let's look at some of the signs and symptoms. So tophi are uric acid crystals in the joints. Podraga is inflammation of the great toe, so that's what that name is. They may also have a fever, usually onset at night. So how do we treat it, right? Medications. For acute care, we use colchicine, indomethacin, some steroids. For maintenance, we use allopurinol and febuxostat and probenecid. So probenecid should not be used with aspirin because aspirin interferes with the effectiveness. But febuxostat can actually cause liver failure, and they may need a low-dose aspirin with that. And allopurinol for any patient with renal stones or renal impairment. Some of the other medications that we would use, losartan, if a person has gout and hypertension because it promotes urate excretion. That's an interesting one. We don't really want to treat this with diuretics because diuretics increase uric acid levels and then can increase gout. And lifestyle modifications are sort of important here, right? They need to limit alcohol, limit their purine, so a lot of dietary teaching goes here. For nursing care, we're going to focus on monitoring their labs, making sure they have adequate fluid intake, at least 2 liters of fluid daily. During the acute care, you need to protect that joint, right? Any touch on the area of inflammation may increase pain, so we want to keep the bedding away from the toe, may use a box that you could put over the feet and lay the blankets over. Tylenol could be used for pain management. It's possible that the person may be on bed rest while we're getting the acute inflammation under control. All right, talk about Lyme disease. It's caused by Borrelia burgdorferi, which is transmitted by ticks. It's more common in the summer months, of course. That's when people are outside and exposed to such things. The characteristic is, of course, that bullseye rash. It appears within 1 month of the exposure. May occur on other places of the body with the disease progression. It's basically got that central redness or a papule and then an outer red ring up to 12 inches. It's warm to the touch but not itchy or painful. And then the person may also develop flu-like symptoms, right? Fever, headache, and Lyme disease can resolve even without treatment, but for some folks, it does not resolve very well and can lead to long-term effects, including arthritis. So we diagnose it by doing an enzyme immunoassay and then a Western blot. And then treatment is doxycycline, 10 to 21 days. However, if they have neurologic or cardiac issues, you may need to use IV ceftriaxone, and some may need extended antibiotics. So that's Lyme disease. Septic arthritis is gonorrhea is actually the most common cause for septic arthritis in sexually active young adults. Bacterial arthritis can be caused, basically that's what it is, a bacterial arthritis caused by bacteria, virus, but again, gonorrhea is the most common for the young folks. It can lead to avascular necrosis. If we were to test the joint, we would want to culture the synovial fluid and then also get blood cultures as well. Treatment is to aspirate and then lavage the joint. They may need surgical intervention, broad spectrum antibiotics. The goal is to treat the infection, control the pain, and maintain their range of motion. So you can see that patient there, septic arthritis, it's unilateral. This is what we are often concerned about after joint replacements, that a person can get septic arthritis as well. Ankylosing spondylitis is a chronic inflammation of the axial skeleton, which leads to fusing. Generally occurs in the 20s to 30s, low back pain, stiffness, and limited range of motion. Basically, it's worse at night and in the morning, but improve with mild activity. Women generally have a lot of neck stiffness, and it may result, as you see in this patient, with severe postural abnormalities. Safety is a huge concern for these people. Mobility is a huge concern. They are at risk for cauda equina and possible fractures from the osteoporosis. We diagnose it based on imaging and labs. They'll have an increasing SED rate, anemia, HLA-B27 antigen would be positive in these patients. And treatment, again, our NSAIDs for pain control and our DMARDs, the same meds we use for rheumatoid arthritis, we use for these guys, but it will not help the central disease, only the peripheral disease. And inflammation in this disease doesn't just affect the skeleton, it also affects the eyes, the heart, the kidneys, the lungs, and the peripheral nervous system. So we can't prevent it, we can't cure it. Goal is to maintain their mobility, manage their pain. We use deep breathing exercises to decrease the risk for pulmonary complications because reduced chest expansion can occur. Exercise is absolutely essential. We use things like hydrotherapy to maintain joint function and pain. When you do your range of motion, be sure to include chest expansion. All right, so it's best to have them sleep on a firm mattress with a flat pillow, and that's because of the flexion deformity that's caused. We want to avoid spinal flexion. All right, so the next thing we're going to talk about is lupus. So lupus is a multi-system inflammatory autoimmune disease. The severity does vary. Its hallmark is exacerbations and remissions as well. It's autoimmune. It may have genetic and environmental links, right? Sun, UV exposure, hormonal influence, some medications like procainamide. It's got basically an unpredictable course. 1.5 million people have it in this United States. 90% of the patients are women, aged 15 to 45 years old, right? Can range from pretty mild disorder to rapidly progressing fatal issues. So let's look at the clinical manifestations. In the skin, person may have the butterfly rash, photosensitivity, lesions in their oral nasopharyngeal, alopecia. They have potential for arthritis, arthralgia, swelling. For the heart, tachypnea, cough, dysrhythmias, cardiac inflammation, high risk for heart attack and strokes. Renal impairment, it can be mild all the way to renal failure requiring dialysis. That's why for our lupus patients, so important to monitor their elevated BUNs and their creatinines, because it could show us that there's lupus nephritis happening, and we might need to change their therapy that they're on to prevent further damage. Person may have seizures, they may have peripheral neuropathy, they may have cognitive issues, problems with the hematologic system, increased infection risk. And here are some of the other clinical manifestations, right? I'm going to move that over for us. So take a moment. And remember that autoimmune disorders often come on the heels of others, so they might have Sjögren's with it. They might have another autoimmune as well. So diagnosis, there's really no specific test. The diagnostic criteria is in your book for the 11th edition. It is on page 1521. For labs, there now is the anti-SM antibody that is found almost exclusively in lupus, and other things we might do, the ANA, the anti-DS, SED-rate, CRP. All right, I want to take a moment to talk about the increased infection risk for these people. They are more susceptible to infections because of the impaired immunity with their autoimmune disorder. Pneumonia would be most common, and to know when and when not to give live vaccines. If a person with lupus calls you and they tell you that they have signs of an infection, they would be a priority patient. They're more likely to have terrible outcomes. So what's our treatment, right? Medications, we use NSAIDs for mild disease and joint pain. So remember, though, our older patients are at increase for renal toxicity caused by NSAIDs, such as naproxen, so we need to monitor their labs. Steroids, oral for mild disease and topical for any of the discoid rashes. Anti-malarial drugs are used to repress the immune system. Hydroxychloroquine is one of the more common of those, and we recall from our other section we need to have routine eye exams with hydroxychloroquine or Plaquenil. Steroids. Steroids should be tapered, but for our lupus patients, they may need large, prolonged doses of steroids, and you need to monitor their weight and I's and O's with them, and also understand that it impairs our glucose, so they may develop some diabetes manifestations. Immunosuppressives need close monitoring. Live virus vaccines such as varicella are contraindicated in patients taking immunosuppressive drugs. And then some additional meds, depending, might be warfarin and our monoclonal antibodies. So the nursing care here is the goal is to avoid major complications and exacerbations. It is to maintain adequate tissue perfusion, promote pain management, avoid renal impairment and decreased renal function. And our nursing care really is, the cornerstone is to avoid the triggers, avoiding the flares. This is key, right? Because an exacerbation can markedly change the course of the disease for a patient. So avoiding those flares is key. All right, we have just a couple more things to look at. One of them is scleroderma. Scleroderma affects the skin, vessels, synovium, skeletal muscles, and the internal organs. It can be localized or systemic. The exact cause is really unknown. It's basically an overproduction of collagen that causes tissue fibrosis and blood vessel occlusion. Vascular problems, including the arteries, occur early, but this can disrupt the function of the lungs, the kidneys, the GI tract. No true single diagnostic test for it, but if we were to try to test it, we would do skin biopsies, pulmonary function studies, checking the heart, ANA. So what you need to know about scleroderma really does revolve around the CREST syndrome. So CREST syndrome stands for calcinosis, so C for calcium deposits in the tissue, R for Raynaud's, E for esophageal dysfunction, S for sclerodactyly, and that's where the fingers may stay in a sort of semi-flexed position, and T for telangiectasia, and that is that redness, that capillary dilation you see there. You may also have internal organ involvement. The pulmonary hypertension would be the main cause of death here. Renal disease, heart disease as well. Labs may show hemolytic anemia. All right, so treatment. The medications are on table 6419 in the textbook. We use some vasoactive agents, calcium channel blockers, angiotensin II. Keeping the room warm will decrease the incidence of Raynaud's, which is one aspect of CREST. Capsaicin can improve circulation, decrease pain. Because of the esophageal manifestations and scarring, patients should be sitting up a couple hours after eating. Might use some paraffin lotions on the skin. Patients need to continue range of motion. So that's pretty much that. I will give you, even though you don't have a slide for it, we're going to talk about Sjögren's for just a minute. Sjögren's is an autoimmune disorder. You've heard me say it a couple of times. It targets the exocrine glands, more common in women, but it also comes along with things like Graves' and Hashimoto's. A couple of medications, you can read them in your textbook, but to know that Sjögren's, right, biggest thing is the dryness. We do problems with the dry eyes and salivary glands, so treatment basically aimed at that. And then fibromyalgia. Fibromyalgia, then we'll take a little bit of nod to chronic fatigue. Fibromyalgia is a chronic central pain syndrome. It's non-articular musculoskeletal pain. It tends to wax and wane. Dietitians do suggest that patients with fibromyalgia limit their intake of caffeine or sugar because those are actually muscle irritants. Best treatment is exercising, mild exercise like walking, but vigorous exercise can make it worse. Patient may need to adapt their lifestyle to their ability to do self-care and their symptoms. Over-the-counter meds are frequently used. Also, we use some adjunct treatments like pregabalin, which is Lyrica, duloxetine, tricyclic antidepressants. Yeah, the person is the hallmark for this is called allodynia. So basically, it's pain out of proportion to what you're doing, and the trigger. They have these tender points, these trigger areas, and I'm learning a lot more about this as we go on. It used to be seen as more of a psychiatric disorder, but we are now seeing that we can actually pick up, and we're on the way to having a lab test for it. So we talked about that. The diagnosis. So treatment, guys, the opioids are not recommended for treatment of fibromyalgia. And chronic fatigue syndrome often would be talked about in the same vein as fibromyalgia, so we'll just take a little nod to it. It's basically it's profound fatigue, but with no definitive treatment. So at least fibromyalgia has some treatments. So guys, that is the end of Musculoskeletal. I thank you for joining me, and I will see you in class.